Okay, thank you very much for letting me speak today. My name is Eileen Blackstone. I'm the EMS coordinator for Mesa Fire Medical Department. I was hired full-time back in March to oversee the paramedic program. So my background was about 10 years working for Native Air, and I did 10 years over at Aerovac, where I was actually part of the maternal team working at Aerovac 1 at Sky Harbor. Absolutely loved my time at PHI, working with the fill truck and with doing the outreach education. So today we're going to talk about some emergency delivery and newborn stabilization. Understand that this, when I created this lecture, it's kind of for a lot of different areas, but I'll touch on some of the changes that CAREMS has versus what's in the presentation and some of the differences that we'll see in the pre-hospital environment. So first thing we're going to do is talk about fetal development. In utero, once the sperm has gone towards the egg, all the sperm actually will head towards that ovum. And once one sperm goes ahead and gets into the ovum, there is a hard, it makes it a kind of a hard, crusty area so that no other sperm can get out. It releases a chemical that creates that shell so that no other sperm can penetrate that egg. So at the end of 4 weeks, our embryo is going to be about 1/4 of an inch in length. The heart, digestive system, backbone all begin to form. Placenta, the afterbirth, starts to develop. So at 4 weeks, we aren't going to see a lot of emergencies. She may or may not know she's pregnant at this stage. And probably the most common thing that we'll get called for is maybe some bleeding, some spotting, and we might even get a occasional miscarriage that happens now that just kind of acts like a bad period. But for the most part, at 4 weeks, not a lot of changes that we have to worry about pre-hospital. So here's our 5-week-old embryo. My clicker pointer's not working. So you can see here, we've got some earbuds that are starting, some little eyes that are starting to form. Your backbone is out here. But if identifiable, if she did miscarry or didn't have the pregnancy hold, just a blood clot is all you'd be able to identify. So at the end of 8 weeks, at this point, she should know, she should have had a missed period, so she should know she's pregnant at this. Eyes, nose, lips, and tongue are starting to form. And you can start to see the embryo, you can start having some arms that are more identifiable, the ears are more identifiable, the eyes. So penis will begin to appear in boys. Embryo's moving, although at this stage, mom can't feel the baby move, but the heart is functioning. Overall, at 8 weeks, the emergencies that we're going to see might be nausea, vomiting, maybe a miscarriage at this stage where she's bleeding a lot, maybe having some cramping. So we just treat the signs and symptoms that we're going to see. If she did pass any clots, I would take whatever clots you can to the hospital with the patient. But for the most part, at 8 weeks, maybe some nausea, some vomiting, and potentially a miscarriage at that stage. So at 12 weeks, our fetus is 2.5 to 3 inches, weighs about 1/2 inch to an ounce. Nails are starting to develop, hands, arms, feet, legs are starting to become more identifiable. Heart rate can be felt or heard over 10 weeks, but you need to have a specialized Doppler. So at 12 weeks, we are now went from embryo stage over to fetus. Again, the fetal heart tones with a Doppler, and you can see there's even more identifiable markings with the legs starting to develop, with toes, fingers, arms are starting to develop, ears are starting to get more identifiable, eyes. But this is the stage where the fetus is most vulnerable to toxins. So if the baby or mom is going to miscarry or is going to spontaneously have an abortion, it is done at this stage. So usually if she hits 12 weeks, that's our first marker that things are going to probably go well and that she's going to continue to have the baby at full term. But up to this stage, up to 12 weeks is usually the hit or miss. The body may just say, I'm not going to keep the pregnancy and just discard the pregnancy. So at that stage, this is the pretty much the first marker that she can have a successful pregnancy. So at 4 months, we're sitting right about 16 weeks. Our fetus is 6.5 to 7 inches, weighs about 6 to 7 ounces. Fetus can have sucking reflexes, tooth buds are developing, sweat glands are forming. Sex is identifiable at this stage. Usually between 16 and 18 weeks is when they'll bring mom in and they'll either do whatever they do on YouTube and TikTok now with having gender reveal parties. tell mom and dad whether if they want to know the sex of the baby. This is the stage where they'll go ahead and let mom and dad know what the sex is. So here's your 16-week fetus, so you can start seeing even more identifiable, gaining a little bit of weight, getting a little bit bigger. So at 5 months, we're sitting right about 20 weeks. Fetus is 8 to 10 inches, weighs about 1 pound at this stage. Hair begins to grow. You'll have the mom will start to feel fetal movement. So this becomes really important in our assessments. We don't have X-ray vision, so we can't really tell what's going on. But if mom has felt the baby move, what I tell them at this stage is that tell me every time you feel that baby move. So, and I want to document that in my chart. So I'll be very careful to say every time you feel the baby move, just put your hand up. And in my chart, in my narrative, I always put fetal movement felt at, and I'll put the times listed that she felt that. Bradycardic babies don't move around. They will go ahead and be limp in utero. So if she's feeling the baby move, that tells me that we've got a heart rate that's not bradycardic, or we have a baby that's not bradycardic. So I want to make sure I'm very careful to document that as we go. So viability comes into play. I can tell you that depending on the different hospital, the different facilities, 24 weeks is the time that you can do a full court press, and you have a chance of a baby coming out of the hospital with maybe some limited or some challenges, but maybe not so a lot of significant problems. There are hospitals that will start resuscitation earlier. It just depends on what's going on with the baby, what the family's wishes are. If there is a chance, it just depends on what the different things are. Our goal as pre-hospital providers is to try and keep the baby in utero as much as possible. And if there is a delivery, usually under 24 weeks, it's very limited in the pre-hospital environment that we have a successful transfer to a hospital with a baby that survives versus not. So 24 weeks is where we really like to be. And our goal as pre-hospital providers is to keep that baby in utero as long as possible. So at 6 months, fetus is 11 to 14 inches, weighs about 1 3/4 to 2 pounds. The eyelids begin to part and eyes open occasionally, short periods of time. Skin's covered with protective coating, and the fetus at this point is actually able to hiccup. So 24 weeks, again, is our really viable situation. You can always call if you have a situation where a mom is going to be delivering. Her bag of water is ruptured and she's less than 24 weeks, and the hospital can go ahead and advise you on what to do at that point. Understand, like I said, 24 weeks is your best shot at getting a fetus that doesn't need a lot of, or will still need some resuscitation, but has a chance of coming out of the hospital at the end. 28 weeks, fetus is 14 to 16, weighs 2.5 to 3.5 pounds. Taste buds, fat layers, organs, and skin is wrinkled and kind of reddish. If born right now, kind of looks like a wrinkly old man. This is a preterm baby and will be that way until they hit the 40 weeks. I have 2 preterm babies at home. I have a 27 and a 28 weeker, 2.5 and 2 pounds, 9 ounces were their weights. And my neonatologist told me at the very beginning, he said, at this point, understand, it's going to take 40 weeks to grow a baby, whether it's in utero or out. So that baby ended up, both kids ended up in the NICU at St. Joe's till they hit about 36 to 38 weeks. I did max out AJ Fire. It was at the times their insurance policies, so they are $1 million babies. So preemies are very, 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 very expensive. Back 30 years ago when I had them, it was $40,000 a day in a NICU. So it is a lot of money, and you will go through your insurance policies very quickly on neonates. And both my kids were pretty stable neonates at that rate. So at this point, when we hit the 28-week mark, you've got a 50-50 shot at these kids coming out and breathing on their own. 30 weeks is the magic number we want to see on your CAD system, or what we want to see if we get to the house and we have a delivery that's taken place. At 30 weeks, if they're born, there's a really good shot they're going to be breathing on their own. Under 30 weeks, you may have to intubate them or at least bag valve mask them until you can get them to the hospital. 50-50 shot at that stage. One kid, the 2 pound, 9 ounce kid, was intubated. The other one was not. So I had one intubated and one not on delivery. The most important thing at this stage is surfactants necessary to get the lungs to develop. So surfactant is that liquid that's in your lungs that keeps your lungs from sticking together every time you exhale. So it's kind of like a balloon effect. If you were blowing up a balloon, the amount of pressure you have to use to inflate that balloon is kind of what would happen if you had no surfactant in your lungs. So at 28 weeks, they still don't have surfactant. Aerovac used to, their maternal team carries the artificial surfactant. You actually intubate this child, you put the artificial surfactant in, you slowly, gently move the baby around so that it covers all of the areas of the lungs. And that's how you get artificial surfactant into the lungs. They carry it. A lot of hospitals don't carry it because it is extremely expensive. And when it expires, it really goes down the drain. But hospitals that are dealing with 36-week babies, they really don't have to have that in stock because they know they're going to call for maternal team to come take the kid out, and they carry it there. So artificial surfactant is important for your lungs, helps increase ventilation, helps increase oxygenation, and it is important. But at 28 weeks, you got a 50-50 shot at those kids having surfactant in their lungs, and that's what's going to determine. So what do we do pre-hospital? On your bag valve mask, you have a pop-off valve, and that pop-off valve is set at 40 centimeters of water. It's usually unattached so that when you go ahead and squeeze the bag, anything that's excessive blows off of that tube. However, if you need to put higher pressures in because you're not getting inflation because your kid has no surfactant in their lungs yet, you may have to engage that so that you have to put more pressure into the lungs. I say that very gingerly because if you put too much pressure in the lungs and they get a pneumothorax, there's only one place they got that pneumothorax, and it was you bagging that kid. However, if you don't make the lungs go up and down, or the chest go up and down and the lungs inflate, you're not going to have a viable child. So understand, you can engage that so you can put more pressure in, but be very careful when you're doing that because you could overinflate the lungs and you can end up causing a pneumothorax. So here's your 32 weeks. So we have fetus is 6.5 to 18 inches long, will weigh about 4 to 6 pounds. Overall growth is rapid at this stage. Essentially, all the organs are there. They're all in place. All this kid needs to do is just lay around and literally gain some weight and get big enough so that the birthing process can take place. So at 38 weeks, we have 19 to 20 inches long, weighs about 7 to 7.5 pounds, lungs mature. Birthing at this stage should not be a problem. We should be able to help mom with the delivery process, and you should be able to have a pretty healthy, intact fetus or baby at that stage. So let's talk about some changes that's going to go through mom. Every one of her systems is going to go ahead and change or have an effect on what's going on with her. Reproductive, cardiovascular, respiratory, urinary changes, GI, musculoskeletal, metabolic, and even some endocrine changes will take place in mom. First thing is her uterus. It's going to increase in size 20 times. It goes from 70 grams and will go up to about 1,000 grams by the end of the pregnancy. So this is a very vascular organ that is sticking out and sitting right in front of mom. So if mom falls, there's a good chance if she has any problems, she could end up with a ruptured uterus. She could end up having an abruption. A lot of different things can go on. So understand it's a very vascular organ that actually comes up front that doesn't really have the protection it normally does when mom is not pregnant. It's also the cervix is softened, increased mucus production. This becomes important because very few women get to 40 weeks of pregnancy and go deliver a baby without there being some kind of infection that takes place, whether it's a UTI, whether it is a vaginitis, a whole bunch of different things that can go on because it is a perfect storm for a infectious area. So understand, make sure you get temperatures on your mom, kind of rule out cramping is one thing, and preterm labor might be there, but also try and eliminate the fact that she also could have a fever, and this could end up being the problem with why mom called 911. So we have our reproductive structures. We have a placenta, umbilical cord, amniotic fluid, and the amniotic sac. So the first thing we're going to talk about is the cord. You have 2 arteries, 1 vein, kind of looks like this. Understand that in our CARMS guidelines in pre-hospital, it's listed as an STR to cannulate an umbilical catheter. So I did this lecture all over the state, and one of the fire departments to the west of us that I did this lecture for, their medical director came up afterwards and said, "Hey man, you told my people something wrong. You said that they could not do umbilical catheters." And I said, "Well, you can't. It's not, at that time they were not part of the STRs." He goes, "Well, I allow my people to do them, and we check them off every year, and they can do umbilical casts." Only fire department I know of in the state that allows that. Understand that this is a very sensitive area as far as you're inserting something directly into that umbilical catheter, and that can end up, if you go too far, you can end up lacerating the liver. Now you've got some bleeding problems, but also pre-hospital. We also are now doing something that's a sterile technique in a very unsterile environment. So the chance of infection goes up dramatically. So it is not part of Mesa Fire's STRs to do umbilical caths. So don't, this is a great place that you can check for a pulse. You'll get great core pulses on this cord. There was a while back when I was teaching medic school somewhere else, and someone came in and said, you can cannulate the side of the catheter and get an IV that way. That is not acceptable. So you have your Jamsheeties that you can start IVs. You can start looking for your ACs for peripheral IV access. But cannulating your umbilical catheters, not something that we're going to do at Mesa Fire. So your amniotic sac and fluid. So this fluid accumulates rapidly. We start at 175 to 250 milliliters at 15 weeks. We'll go up to about a liter when we hit term. Now with that liter of fluid, and then you add about 500 to 1,000 more of blood loss that it takes place. So you have a woman that's going to drop 2 liters of fluid from her central system very quickly. Not a big deal when you're 25 or even 30 for that matter. But you have women now that are waiting to get pregnant that are well into their 40s and 50s. So if you take 2 liters of fluid off of this person right away, it's not going to go well. They're going to have other underlying cardiac problems that could be intact, and they can end up falling and tripping and not feeling well, getting very dizzy. So at this point, we do all the movement for moms. We assist them if we're having them walk anywhere. But just understand she's going to lose a lot of fluid, and that could be an issue for these moms. Lowest amount is age 9. We had a girl that was pregnant in the state of Kentucky, delivered at 10, so unbelievable. Oldest is 73 or 74, who in Sweden did in vitro or in artificial implantation of the eggs, and ended up delivering at 74, 75, twins. So when you've got a woman of abdominal pain of childbearing age is 9 to 73 or 74. That's a lot of age bracket difference. So understand that when she loses the fluid, you've got a whole bunch of other medical problems that are going to take place. So keep mom flat, keep her moving, and transport her appropriately. So some cardiovascular changes. Her heart's going to increase in size and come a little bit more central from the left side over underneath the sternum a little bit more, trying to make room for this baby and all of the parts that go with it. But the most important thing is hemodynamically, her blood volume will increase, but her blood pressure drops in the second trimester. This becomes really important because we want to know, when we ask mom questions about her history, what your blood pressure was and what's been your history with your blood pressure. So if I know my second trimester, my blood pressure drops in the second trimester, if she started off in the 130s or 140s, and second trimester she's dropped to the 130s to 140s, and now I know it's going to go back to normal, she's actually considered preeclamptic at that stage. So finding out the blood pressure, and if she's in her second trimester and it's on the lower, even close to being in the 130s to 140s, understand that the third trimester, things are going to go worse than they were in the second trimester. So keep an eye on that blood pressure. That's going to be a really good indicator for the fact that she could be preeclamptic. So respiratory changes, when I was pregnant, those 30 years ago, we didn't take anything. If you took an extra aspirin or you took an extra a vitamin or something, if your doctor didn't okay it, you were going to have a kid that had 3 foreheads, came out not being able to get in Harvard, all kinds of crazy things. So a lot of moms that had asthma stopped their medications because you didn't want to take anything when you were pregnant. That's not necessarily the thought process now. If with proper prenatal care, if they've got medical history or medical conditions that they need to address, they're going to keep doing that, and they are going to address those medical conditions. But that's done under the care of a physician that will say, these are safe for the placenta and the baby, these are not. This medication will cross the placenta, this one won't, and they may make some changes. But understand that you may get a mom with a history taking medications that 25, 30 years ago, we didn't have them take. But we found out that when mom doesn't take her asthma medication, now she has an asthma attack, that baby becomes hypoxic. So moms will end up taking meds they didn't take in the past. So some urinary changes, she increases her urinary production and she also increases the times that she goes to the bathroom. The baby, you've got a great big beach ball that's now sitting right here under your urethra next to your bladder. And as this pregnancy grows, this baby can end up kicking the bladder. So mom thinks she's either had her water break or she's ended up just peeing herself all the time, or she makes a lot of frequent trips to the bathroom. So understand that that is one of the things that changes with her urinary production. She was going to increase. She's drinking a lot more water. There's a second baby, and there's a baby involved, and now that baby could end up kicking that bladder. Some of the GI changes. So understand that her belly is going to always have food in it. She doesn't eat 3 meals a day. She eats like 10 small meals a day. So there's always something in her stomach. And why is that important to us in the pre-hospital environment is if you go to intubate this mom, if she's unconscious and you've decided she needs an advanced airway, there's a very good shot as you go in to intubate this mom, you're going to end up having food coming up. So get suction ready, have that ready to go. And understand that we do have an OG tube that we can use on mom. And it's a fantastic device, especially if you just intubated, keep your blade in there and you can slide your OG tube right behind it. And now you've got a pathway to start emptying that belly. So if you're intubating either a pediatric patient or you're intubating a pregnant mom, OG tubes are a must. Your OG tube, my husband worked for Superstition Fire or AJ Fire, and they, I always have a list on the side of my refrigerators, reasons why I didn't do an OG tube. And he's a great medic. He did a great job when he was, he's retired now. But when I worked there, I used to CQI his charts, and he'd have 1 or 2 pregnant women. I'm like, but you didn't do an OG tube. And he'd be like, well, I didn't have the equipment with me. It was in the ambulance. We were too close to the hospital. So there's a list on the side of my refrigerator of why I didn't do an OG tube. And I go, just tell me number 4. You're just too lazy to do it. And that was what he would, 9 times out of 10 was the problem. So anyway, OG tubes are great. Double your ET tube size. If I'm going to intubate mom with a 7.0 ET tube, 14 French is what I'm going to use for an OG tube. If I'm going to intubate a newborn baby with an 8.0 or 4.0 ET tube, I double that, and I'm going to use an 8 French feeding tube for an OG tube. If I'm going to intubate somebody with a 9.0 ET tube, I'd use an 18 French. So just double that ET tube size, and that's going to tell you what size OG tube you should go ahead and use. Metabolic changes. So normal weight gain on this mom is going to be between 11 and 16 kilograms. That is a worldwide average. What do you think the average is for the United States? 60 pounds is the average. So our moms get put on some weight. They're really, American Heart still has 140 as a systolic blood pressure for preeclampsia. We'll talk about that here in a second. But we're trying to keep mom's weights down into this bracket. Again, something that her and her physician will decide what's healthy, what's not healthy, what she should do and what she shouldn't do. But we end up with a lot of weight gain. So out of this presentation, this is still my favorite slide after all these years. I'm not going to be able to point to it. But if you've got a mom on the side of the road that's unconscious, you know she's pregnant, but you don't know how far along she is, and that's going to determine which hospital am I going to go to. The most important thing is to understand the umbilical line on her belly is going to tell me viability. So if you start low on where the pubic bone is and work up, you should have a nice firm surface. And as soon as you feel it kind of like a spare tire, it kind of goes off to the side or gets kind of smushy, that's the top of your fundus. And that is the end of your uterus. So if I have it nice and hard and it's above the belly button, that tells me I've got a viable fetus. If it's under the belly button, I haven't hit viability yet. So you might be able to go to a different hospital, a little closer hospital, depending on what's going on with her, but understand that belly button equals viable fetus. So make sure in our moms we do a good head to toe. Contractions are always going to be measured from the start of one contraction to the start of the second contraction. Note the frequency, the duration, if she's having any pain with those. You need to note any leaking fluid. Is it clear? Or does it have meconium in it? Any bleeding, vital signs. Make sure we include fetal heart tones and check for lung sounds. So after about 21 weeks, you can sometimes hear the baby's heart tone with a stethoscope. So what you do is start low on the right side. You need to know what mom's pulse rate is because there's a very good shot you're going to find mom's pulse as you're doing this. And you just take that stethoscope and work your way over come up a little bit and work your way around and see if you can find the heart rate. If I do find it, I'll note what quadrant I had it in, lower right, lower left quadrant. But anything over about 21 weeks, you can sometimes, depending on how fluffy mom is, find that umbilical or find those fetal heart tones. They should hopefully be anywhere between 120 and 160. So high flow too, if she needs it. So again, you're going to judge that based on what mom's oxygenation is. Large bore IVs, we want to stay away from the AC if possible. Hands and arms work the best. But if we don't have any other port and storm, then and that's what we have to use. That's what we're going to use. But try and get one, if not two IVs for the receiving facility. Vital signs, including fetal heart tones. If you're taking a national registry test, you'll always put moms on their left side. However, if she's on her left side and she doesn't feel fetal movement, I'll move mom to the right side, try and piss off that baby and wake that baby up, and then I'll move her back to the left. So I keep going back and forth until I can get that baby's heart rate hopefully coming up. If the patient's on a backboard, you can go ahead and tilt the backboard. You don't have to tilt it up sideways. Just take a bag of IV fluid, like a bag of saline or lactated ringers, and put that underneath the board. And that's enough to get the great vessels off of the, or get the blood supply moving from the inferior vena cava. So we're going to talk about now some OB emergencies. So the first one is going to be that supine hypotensive syndrome. Mom lays flat and it compresses the inferior vena cava. When that happens, as soon as mom wakes up and that blood, or sits up and that blood supply starts to move, we now end up having where mom gets very flush. She could pass out. So it becomes a problem. What we want to do, it's the third trimester in pregnancy is when it occurs. We want to go ahead and just manipulate mom. So move the mom off the great vessels. And now you've got blood supply moving back to the vena cava. So again, just a little bit, all it takes is a bag of IV fluid or a rag underneath that hip, and then it'll be off the vessels. Preeclampsia or toxemia, this is going to hypertension of an unknown disorder. It only occurs in 5 to 8% of pregnancies. However, it's 25% of maternal deaths. So not a lot, but when it does happen, it's a big ticket item. It's associated with maternal age. Women are waiting longer to get pregnant, and they have chronic hypertension. They have renal disease, diabetes, lupus, or even multiple births can add to the toxemia. So we have this triad of hypertension, blood pressure greater than 140/90. Again, American Heart has been looking very strongly at lowering that number to the 130s/90. It has not come out in the 2020 guidelines for American Heart, but when 2025 hits, I wouldn't be surprised to see that number come down a little bit. But anytime you have a rise in 30 millimeters of mercury in the systolic pressure or a change in 15 in the diastolic from her pre-pregnancy blood pressure, that puts her in the preeclamptic category. She can also have edema, or when she goes to the doctor's office, the first thing they do is dip her urine, and they're checking for that protein in the urine. And if that comes back positive, then you end up having positive for preeclampsia. So ABCs, oxygen therapy if necessary, place the patient on the left lateral recumbent position, gently handle her. This is the time where mom's in charge. If she doesn't like your ball cap, you take your ball cap off. She thinks the sky is purple, the sky's purple. She doesn't like her husband, the husband doesn't have to ride in the ambulance with her, we send him in the car. Whatever we do to keep mom's blood pressure low and keep her calm is what we'll end up doing. A lot of times they want nice and quiet in the back of the ambulance, cool, and making things as dark as possible, just no stressors, no lights and sirens, just try and keep her as calm as possible. We'll check a blood glucose if they haven't done one. If she hasn't had one done lately. IV is mag sulfate if we need to start considering treating for the preeclampsia. And then we want to make sure that we patch and let them know what we have. So part of preeclampsia, if you've ever heard of HELLP syndrome, you may not, unless mom has had a history of it in the past. But HELLP is going to end up having to do with blood that they'll draw at the hospital. So a lot of times, if you're transporting mom for the first time, she may not know the acronym for HELLP, but your HELLP is your hemolysis, elevated liver enzymes, low platelet count, and it occurs in approximately 20% of women with severe preeclampsia. Signs and symptoms, the elevated liver enzymes, low platelet, abdominal pain, blurred vision, headache, edema. Those are all the same signs and symptoms that you're going to end up seeing with preeclampsia. It's just one stage worse than your preeclampsia. And again, we won't know that pre-hospital, but it's something nice to know. When she gets to the hospital, the treatment for it, they'll probably end up maintaining her blood pressure or treating some blood pressure issues with some blood and mag sulfate for seizure activity prophylactically. So eclampsia is that really, really, really bad seizure. When she has that seizure, she left preeclampsia land and now she's sitting in eclampsia land. Same signs and symptoms as preeclampsia, except now we have seizure activity and potentially a coma. ABCs, oxygen therapy if necessary, we consider intubation, your mag sulfate, and I'll bring up the CARMS guidelines here in a second because you have two different topics on mag sulfate. So 5 grams IV over 10 to 15 minutes, you take 4 grams, put it in your 100 milliliter, but refer to your standing guidelines. If this doesn't work, then we need to start considering some benzos, which is your Ativan, Valium, or Versed for seizure activity. So down here here's your preeclampsia guidelines here. For seizure prophylactically, it's 4 grams over 10 to 15 minutes, followed by a 2 gram per hour IV maintenance. And then for seizure management, it's 5 grams over 5 to 10 minutes. And then if that is not working, we're going to go ahead and treat them for seizure activity with your benzos, and nausea vomiting, referred to your nausea vomiting category. I will tell you, with both kids, I was on mag sulfate. Great drug. I felt horrible on it. It is the most horrible drug in the entire world. It feels like gasoline going through your veins. I had my younger son in January, so in December, I had the air conditioning blowing, laying in bed in the hospital bed at St. Joe's with just a sheet on, and I was so warm. Everyone else was in a parka. I was literally drenching in sweat, and a lot of it was the side effects of the mag sulfate. Nausea vomiting is a real thing, and it's not just nausea vomiting. She will projectile vomit all over the place. So if you're going to start thinking about giving your mom's mag sulfate, I would really consider some Zofran prior to, so that you don't end up with some of that horrible nausea vomiting. She will feel horrible when she's getting this medication. So giving her some advice is like, it's good for the baby, it's good for you. I know it doesn't make you feel good. However, this is a good thing. So if we give her too much mag sulfate, we can end up having magnesium toxicity. It's not something we're going to see pre-hospital, but if you're giving a drug, you should know some of the side effects of that. We'll check deep tendon reflexes, irregular heartbeats can happen, loss of respiratory drive are big things for us pre-hospital. Antidote for mag toxicity is going to end up being your calcium gluconate. So let's talk about placenta abruption. So you can see here on the bottom section, this placenta is nice and pink, and it actually has all the areas here intact, whereas up here, it's dark and you have tearing areas. So that's where the placenta was torn away from the side of the uterus. Now, inside the middle of this, I know anytime you ever took a test, it always talked about a lot of blood and a lot of pain. Not necessarily true. So you can end up having losing up to 500 to 1 liter of fluid just sitting here in the middle of this placenta before it ruptures or it goes ahead and tears away from the side of it. So understand that she may not have one right now, but she very easily could have an abruption. So signs and symptoms we're looking at mostly due to trauma, whether she fell or the lap belt. A lot of pregnant moms will put their arm through the shoulder belt, and they end up, when they get into an accident, the shoulder will pull and end up going right across her belly, which is where the seatbelt is sitting now. So understand that trauma, we have a high index of suspicion that something is wrong if she's been involved in a trauma situation and she's got any kind of lower abdominal pain. One of the best stories I heard came from Salt River Fire. They had a patient that was 40 weeks pregnant. She was going to her doctor's office for an appointment, and she got rear-ended. It did deploy her airbag, so it was a pretty good bump, and they kind of shamed her into going to the hospital. Look, we don't have x-ray vision. We don't know what's going on. We want to help you. You should really go to the hospital. They kind of shamed her into going. She would only go to the hospital if she could go to Scottsdale, and Scottsdale doesn't do trauma with OB. So she wouldn't go to county. They called Scottsdale and said, look, she'll come to you, but we don't have any bleeding. We don't have any cramping. Just got bumped. And they said Scottsdale agreed to take her. So they get her to the hospital, they move her over from the board to over to the bed, and that abruption let loose and blood started coming out. Luckily, this happened there at Scottsdale Osborne, where they were able to do an emergency C-section and get the baby out. However, if she had not gone to the hospital and she ended up down at the doctor's office where she was going, that would have been a nightmare of a call for Scottsdale Fire Department. Now you're having to deal with a lady who just abrupted, and you're having to now take her and over to the hospital, and it probably would not have had a good outcome for that baby. Mom and baby both did well, but when she abrupted and everything let loose, it was at an emergency room. So high just a suspicion. If you think that there's a potential that there's something wrong with mom and that the mechanism of injury is there, she needs to go to the hospital and get checked out and get an ultrasound to make sure that she doesn't have an abruption that's starting. So often fatal to the fetus unless it's partial. Risk factors: preeclampsia, hypertension, multiple pregnancies, trauma, short cord syndrome, abruption in early pregnancies all put her at higher risk for having another abruption. Previa is the lining of, or the placenta actually covers the opening of the vaginal cavity or the cervix. So most of the time we can have a partial, you can have complete, and you can have marginal. If it's a complete, even though this belly is going to start growing, sometimes it'll get out of the way so that mom can deliver vaginally. But if it's a complete, it's probably not going to grow enough to get out of the way. So it's not a big deal as long as you know you have a placenta previa. That just means that Thursday at 3 o'clock, you're going to have a C-section. Not a problem. But if you've had no prenatal care and you don't know that you are a previa, that becomes a problem, because now moms can't deliver, baby's trying to come out. And when baby dies, now you've got mom who's toxic. When we flew for AirVac, we had a lot of pregnancies that were previas that were down in southern Mexico or down in southern Arizona because of the Mexican border. People were trying to cross the border to get into Arizona, and they had limited prenatal care, if any, and undiagnosed previas were pretty common. So understand that partial's not a big problem as long as mom's still early on in the pregnancy. That may grow and that placenta may get out of the way. If not, she's a C-section. So it happens in 1 in every 200 to 250 deliveries. It can be partial or marginal, diagnosed early on. And again, it's fixed by a C-section. So it's painless vaginal bleeding, 3rd trimester, ultrasound will diagnose, and again, a C-section. Uterine rupture, again, number one reason for uterine rupture is the seatbelt improperly placed while mom's driving in cars. Uterine ruptures are usually death to mom and death to baby. And when we bring up the CAREMS guidelines, they talk about doing a uterine displacement technique. So if we are doing CPR on mom and we're doing chest compressions, we've got her laying flat because we really need to do high quality chest compressions. We've proven that chest compressions, the best way to save baby is to save mom. But we now have that decrease of blood supply that's getting back to the heart because this belly is now laying flat on the vena cava. So we need to manually displace this uterus. So the way to do that is you can have one person come to the side, and you can literally push from the right to the left-hand side out of the way, or you can pull it towards you by going on the left side and then pulling it over towards the upper left side. So both of those are acceptable, but if you're doing CPR, you need to start thinking about having one person displace that uterus so that you can get the blood supply back to the heart. So who's at risk for this uterine rupture? Multiple births. I still want to figure out what her gravida para is all these years, and I still haven't done that. You have Octomom here who had all those babies at one time. That uterus has stretched more than what anyone ever anticipated. So if she tries to get pregnant again, there's a very good chance that she can end up with a uterine rupture. She's doing porn now, I think, so I don't think we have to worry about more births, but you never know. Kind of an interesting person, but a lot of babies that took place. Prolapse cord. So prolapse cord, normally we have the head that's coming down and it's putting pressure on your cord. As soon as you see a cord, fingers need to go inside. Most of the time when babies are coming out, they're going to be facing down. So if you go low, you can try and find the nose so that you can lift that head off of the cord. Make sure you protect the cord. Make sure you wrap it up in a sterile dressing. But prolapse cord, you need to start thinking about how many people you have with you. So if I have myself and another EMT, someone's driving the ambulance, so my fingers are going in. If I'm on an engine company, I'm going to probably find my EMT. Sorry, EMTs, it's a BLS skill. Your fingers are going in. So someone's fingers have to go in. I need somebody to handle an airway. I need someone to push meds. So it's probably not going to be my medic partners, but your fingers are going in and they're going in for the duration. So you will probably go all the way to the OR with this patient before they go ahead and you take your fingers out. So make sure it's somebody that you can afford to lose for a while. So cord comes out before the baby, don't replace. This is a decreased oxygenation to the baby, which is why our fingers go in to get the head off of that cord. Try and get mom legs elevated, try and get her butt in the air as much as possible. Try and get some of that pressure off that cord. Again, wrap in a sterile dressing. Think about giving mom oxygen if she needs it. Keep her warm and transport her. 3% of all presentations are going to end up being breech. So breech is something other than the head that comes out first. It's increased at risk for fetal trauma, anoxia, and also prolapsed cords. The head and the shoulders are the two biggest reasons why the cervix is able to dilate to get the pregnancy out. If the legs are coming out first, it gives you a little bit more time to get to the hospital. Definitely something that you want to call ahead to let them know so they can have the team ready for you when you get there. So for our breech deliveries, get them in the D chest position or the butt on the edge of the bed. Make sure you try and flex those legs, try and get that area as wide as possible. Tell mom to pant with each contraction. Again, moist dressing from the cord to prevent umbilical artery spasms. Gloved hand to prevent delivery if unable to deliver in the field. To relieve pressure off the cord. 2 fingers going up to get that head off the cord. Oxygen therapy if she needs it, and rapid transport. Shoulder dystocia is also called the turtle syndrome. Oh, good, it's working now. So if I've got a contraction in mom's head or the baby, I see the baby's head and then it goes away. Another contraction, I see the baby's head, it goes away. See another one, goes away. That tells me we have a shoulder dystocia, so the shoulders are actually stuck in the birth canal. If labor is continuing, this tells me that it's not going to work. The one thing we can do is the McRoberts positioning. So we'll put her in the bed with her legs pushed back as much as possible. And we can put a little bit of pressure here on the pubic bone to try and get that shoulder to release. If not, we need to, again, rapid transport, get an IV in the back of the ambulance so that they don't have to do that at the hospital and get her in so that they can go ahead and get the baby out. So let's talk about what a normal delivery is. So your first stage is going to be your first contraction until the cervix is fully dilated. So you see some hair down there. That's the top of the baby's head. You know that you've gone through your first stage of labor. Second stage is full dilation to until birth. And your third stage is delivery of the placenta. So signs of labor, she has a bloody show. Contractions are regular, getting closer together. And the amniotic sac breaks. You now have your signs that this is actually true labor and not a false labor. So just a few things on the video. The first thing is as the head is coming out, the baby turns to the side and, oh, this is too loud. The head will go ahead and turn, and that's again a great time that you can go ahead and check for the cord being wrapped around the neck. I keep this video, I've been using it for years because I can't find a better one out there that shows a good reduction of cord, how easy it is. So a lot of people will freak out when they see the cord wrapped around the neck, but honestly, if it's just wrapped one time, it really does reduce easily, and you can bring that around very, very gently and take care of it right there. In the video, he does go ahead and suction the mouth and nose, and it's done in that order. He did it, he said it the right way, but he did it differently, but it's mouth, LMNOP, so mouth and then nose. However, in your CAREMs, if you look under the maternal or the birthing process, you'll see that CAREMs is recommending not to suction the airway unless the airway is obstructed or there's meconium present. And we'll talk more about meconium here in a minute because it causes some rebound bradycardia. So those two changes. Note, when you saw him put the first cord on, when he was going to go ahead and cut the cord, he kind of bled that cord back and then put the other clamp on. So this way, when he cut the cord, it doesn't go ahead and splurt all over everybody. So one clamp goes on, bring it, kind of bleed that cord backwards, put the second clamp on, and then you're able to cut the cord. Delivery of the head, place your fingers on the bony part. We can't do episiotomies in the field, so she is going to rupture. She's full term. There's a very good chance she will tear. You can try and bring some of that skin around the head to try and help facilitate that delivery so that you can eliminate how bad that tear is. But understand, because we don't do episiotomies, the only thing that she will end up tearing some if she's a full term. If the amniotic sac doesn't break, then you need to go ahead and break the sac. Found this on Facebook, the things you find on Facebook nowadays. So this is a great picture. This is actually from Greece. They had a C-section, and when they cut the baby, when they cut mom open, take the baby out, baby was still in the sac. So they were able to actually grab a picture, maybe do a TikTok video, who knows? And now you can see the color of the amniotic fluid. So you can see here that this fluid has kind of a tint to it. So it's got all of the respiratory secretions, urine, everything that's going on with that baby's kind of coming in and out. So that is the color of what normal amniotic fluid is. You can see a nice color umbilical cord that's up there. So this baby is still 100% reliant on mom and that placenta for its birthing or for respiratory drive right now. So this kid doesn't know any different, doesn't know he's been born yet. So because that sac hasn't broken. So if the cord is wrapped around the neck, if it's wrapped just once, easily to reduce, just bring it around the head and you're good. If it's wrapped multiple times, you may have to go ahead and cut the cord. If that happens, just make sure probably using trauma shears is better. Be very careful of the skin that's under there. I probably wouldn't put a scalpel under there and try and cut. You know, you can end up cutting the baby, but we definitely have to get that cord unwrapped. So we deliver the shoulder, bring the head, bring that first shoulder down, and that upper shoulder should pop out. Then we bring the baby up, and that should allow the lower shoulder to go ahead and deliver. The other thing that they did in the video is as soon as the baby did deliver, is they took the umbilical cord and they kind of made it go straight. So as that umbilical cord starts to grow or starts to come out even more, that tells you that the placenta is getting ready to deliver. Big baby there. So placentas are not that, it's kind of interesting, a superstition. They had a dad one time, they delivered a baby, they put it in a red bag. You want to take your placenta to the hospital with you. They can do some cord sampling at the hospital, so bringing the placenta is important. He came over to the gurney. This is in West AJ. Those of you that are on the east side Mesa trucks, you know what I'm talking about, the nice area that's there. And dad came over and said, nope, that's my placenta, took the red bag and left with the placenta. He wanted it. They'll give it back to you if you want it. You can do some YouTube searches for things people do with placentas. It's something good to do on your downtime. But for the most part, yeah, placentas need to go to the hospital with moms. Again, suctioning the airway. If you have meconium present or you've got an obstruction to the airway, we'll go ahead and suction the airway. Your cord, we want 4 to 6 inches from the infant's abdomen. Place a second clamp about 2 inches away, and then you'll go ahead and cut in between. APGAR scores, if you've done any deliveries in the field, when you go ahead and get to the hospital, it's like I would do patches and say, hey, I'm bringing in a mom, which you just delivered. And the first thing the nurses want to know on the other end is, what are the APGAR scores? They're like obsessed with APGAR scores, which is good. It tells them what kind of baby's coming in the room. There's done in 1 in 5 minutes, and hopefully the baby will get up to a 10 before you get to the hospital within that 5 minutes. But most babies are going to lose on color, because in utero they run very hypoxic, so or very low for our standards, what an old pulse oximeter has. I had an OB-LS class that I took last week, actually. One of the neonate doctors that was in there said, you know, in utero it can be in the low 80s. Yesterday we had an OB nurse here who said that in utero the O2 sats are in the 50s to 60s. So just know on our standard it's lower than what we are anticipating. But they come out and they're blue. They are 100% dependent on that placenta and mom, so they don't, and they're not breathing on their own. They're breathing the amniotic fluid, so they don't need to be at 96 to 100%. So they usually will lose it on color because they're blue when they're born, and usually on muscle tone because they are in that uterus and they're all crunched up, that it takes them a while to figure out that they can go ahead and stretch their legs. So most babies are born between a 7 to an 8, and hopefully in 5 minutes they're up to a 9 or a 10. So again, the third stage of labor is the delivery of the placenta. If I looked at mom and I saw that she was complete and that we were delivering on scene, I would definitely stay on scene to deliver the baby there. But I wouldn't stay on scene to deliver the placenta. It can take up to 30 minutes, so I definitely start heading towards the hospital. But again, you put the cord long and you'll see it start to grow, and then you're going to know that the placenta is ready to deliver. Usually you'll still feel contractions starting, and that's a good indication that the placenta is ready to deliver. So what do we do for our OB patients? Again, ABCs, vital signs, including fetal heart tones. If we could get those large bore IVs, consider 2 of them if you can. High flow oxygen if needed. So check mom's pulse oximeter. Not all patients need oxygen, but if you do, you can treat accordingly to what the guidelines are. Position, I'd have left or right side. The right answer for any national registry test will always be left, but understand if she's not feeling the baby move on the left, do something to make sure that baby starts moving around. You might move her to the right side and then move her back to the left. But just get her off the great vessels and then transport to the appropriate center. Get a good history on mom. I want to know how many times she's pregnant, and I want to know how many babies she's got. So if she's sitting at an 8 and a 3 and she's pregnant now and that's a 4, I got 4 kids something happened to. So what was the problem? History usually will repeat itself. So if she had problems with pregnancies or having stillborns, then I know I've got a high-risk pregnancy on my hands. I also want to know how many prenatal care visits she's had, or if she's still doing prenatal visits. Any allergies, any medications, any surgeries. I want to know what her age is, obviously. If she's really young or really old, that puts her in a high-risk category. And then I need to know her last menstrual period, the first day of that last menstrual period, and I can figure out her estimated date of confinement based on that. So if I know the first day of her last period, what I'll do is minus 3 months, add 7 days, and that's going to go ahead and get me in that area. I left my OB wheel on my desk, but John Sampson with Aravec used to call it the wheel of misfortune, and it's an OB wheel that will actually, you can put in today's date and see how many weeks pregnant she is, and it'll go ahead and figure that out. And I think an image trend, does an image trend have that you can figure out estimated date of confinement? I haven't spent a lot of time in MESA's image trend. But anyway, you want to know how pregnant she is. Here's your childbirth algorithm for CAREMS. So this will go over everything from shoulder dystocia, prolapse cord, maternal care, breech deliveries. So the upper section is EMTs, and then down here is for your paramedics. So if we have a lot of bleeding, they're actually can consider TXA 1 gram IV bolus for the bleeding for postpartum hemorrhage. Real quick, we'll just talk really quick about some fetal distress. So everything we've talked about this morning, how do we evaluate fetal well-being in utero in the field? And it's all about fetal movement. We don't have all the nice gadgets that they have in the hospital that they can do ultrasounds and they can check the baby's positioning. all we have are just mom telling us she's got fetal movement. And so having that fetal movement tells us, again, we've got a viable baby that's not bradycardic. In the hospital, they can do a couple of other things. They can do external fetal monitoring, internal and amniotic fluid indexes. The monitor is, they end up having two different areas they put on. They've got one that'll check the baby's heart rate and the other one checks for contractions. And it shows up on a monitor like this. So fetal monitoring is kind of like an EKG class. They have classes down at University Phoenix, and they are Banner University downtown, and county used to have them, where they have external fetal monitoring classes. If you're into OB and you ever want to take one, it's a great class. It's amazing what you can go ahead and learn just from this dynamics. So if I look at the heart rate and I see I've got a contraction here, if it's early or late decels, they're able to tell if the baby's clamping the cord or grabbing the cord, if the cord's putting compression on the head, if the baby's having heart problems. It is amazing what they can take a look at that piece of paper, what an OB nurse can tell you about what's happening with that mom. They'll also do in the hospital fluid indexing. So if she's ruptured, they'll go ahead and check these fluid indexes to see how much fluid is in there for the baby. And as long as that baby has enough fluid to stay in utero, they will do everything they can to keep that baby in there. I was ruptured and I ended up having that done twice a day for a couple of weeks. Usually if you're ruptured, you'll deliver within 48 hours. I made it several weeks, which was great because it took Michael from like a 23 to 24 weeker up to the 28 weeks before he was delivered. So it was good, but it was a long process. As long as she doesn't have a fever, they'll let that baby stay in. They're not going to do anything to stop the delivery unless mom has a fever, because then if mom's got a fever, baby's probably sick. They don't want her to get septic, so they'll go ahead and deliver at that point. So the neonatal resuscitation triangle, it's still this inverted pyramid that we all learned. We're in a dry position, suction if we need to stimulate the baby. 9 times out of 10, this is all we have to do. Most important thing being keep these babies dry, keep them warm. Give them a little bit of oxygen if you need to. Establish ventilation if we need to. BVM, and again, depending on how many weeks, you may need to engage that pop-off valve. Rarely do we need to do chest compressions. If we do, it's a 3-to-1 ratio. It's 3 chest compressions to 1 ventilation, and then medications. And we need to do between 100 and 120 events in a minute when we're doing chest compressions with ventilations on a baby. Oh, color. Acrocyanosis, this is what's called. It's when the blue is happening in the arms and the legs. Not a big deal. This can happen. They call these Smurf babies and they'll send them home. However, if I have any grayness or any kind of discoloration to the central area, that's central cyanosis, and that's a big deal. So we want to go ahead and treat that with some oxygen right away and consider ventilating your kids if they need to be ventilated with a BVM. Respirations, everything that we do is going to be based on heart rate, but I want to check respirations as well. Make sure we're positioning them, put them in the right sniffing position. And then this is your NRP guideline. So every 30 seconds, we check a pulse and we go ahead and handle things accordingly based on that pulse. So the only 2 numbers we have to remember now is 60 and 100. If our heart rate is less than 60, we're going to go ahead and do chest compressions with ventilation, and that's that 3-to-1 ratio. And then if our heart rate is anywhere between 60 and 100, we can go with a BVM, just 1 breath every 3 seconds. And if it's greater than 100, we can go with some blow-by, give the baby back to mom. But every 30 seconds, we check for a pulse, and we're going to act accordingly based on what we're seeing. So meconium is baby's first bowel movement that took place in utero. Bad thing because this tells me this baby freaked out enough that it actually had its first bowel movement. So that tells me that something happened, whether that baby had the cord in its hand and squeezed it, or the head contracted, but something made that baby so stressed that he had his first bowel movement. So meconium, if that's present, I ask myself, is my baby vigorous? And if my baby is not vigorous, I'm going to go ahead and suction the mouth and the trachea. If my baby's vigorous, I go ahead and just go with my next steps. If my baby's not vigorous, we'll suction the mouth and the trachea. Vigorous is defined as strong respiratory effort, good muscle tone, heart rate greater than 100. We're all set. If it's not vigorous, then we're going to need to do something about that. we'll end up suctioning the trachea. So first thing I have to ask myself, you have 2 sets of ET tubes in your truck. So I'm going to intubate my kids with a 4.0 ET tube. So I take one 4.0 ET tube and I put that aside. I'm not even going to use it, but I'm going to use my other 4.0. And if I need to use more, I'll use the 3.5 ET tubes as well. But the one 4.0 I put aside in case I have to go ahead and intubate this kid for transport to the hospital. So you can see here how they're suctioning. They put the suction meconium aspirator on the end, and you can see this kid is not vigorous. This kid is not moving around, not doing well. So what they end up doing is putting the ET tube in. They put the meconium aspirator on the end, and then they suction on the way out. And they'll do that several times. So this is something that you're trying to get all that meconium out, that you're going to suction until it's clear. So you can do 3 to 4 attempts of trying to get that meconium out, because getting the most out is going to be the best outcome for this kid. So premature babies, anyone born before 32 weeks, keep them warm, keep them sweet, and keep them dry. So check your blood sugars on them. Any considerations we need to make sure that we go ahead and do, but the biggest challenge you're going to have is keeping these kids warm. And that is because they have, they don't have any fat on their skin, they're premature, so they ended up able to lose a lot of heat very quickly. So Sally Herman is a nurse that we flew with at Aerovac, and she has baggies that she used to take over to Africa when she goes and does her trips over there. She puts all her kids in a bag. She cuts the top of the bag off, slides the baby in, and you're able to go ahead and keep the baby warm that way. So the head goes through the bag, not in the bag, and you end up ventilating so that you can use that. The nurse yesterday said that you can take the bag and just wrap the baby around it, which you can do. The other thing that I found useful is the bag that the OB equipment comes in is a great thing to use as a device that you can go ahead and use to keep that baby warm. So again, warm, sweet, a little blow by if you need it, check pulse, treat appropriately. You may need to consider medications and intubate for most part. Transport to the hospital, make sure you call ahead of time so they know what they're dealing with. Here's your different prenatal facilities of what everybody can do. You have a level 2, 3A, 3B, and a level 4 facility. The only level 4 is going to be University Medical Center down in Phoenix. That means that they're doing multiple births and in utero surgeries, all kinds of crazy stuff. So your level 3B is what we're mostly going to be dealing with. Banner Desert is a level 3B, so they're on the higher side. It means they can handle a pregnancy any age, and they can have the ventilators acceptable for newborns if delivered then. So Banner Thunderbird, Scottsdale Shea County, Phoenix Children's, and St. Joe's are all in that 3B category. And on the back of your CAREMS has those categories, and they also have what they do for each one. So if you get on scene and you see that you've got a baby that's 27 weeks, going to a 3A facility is not going to be where you want to go. You want to go to your Banner Desert because they're going to end up being taking care of that baby. If she delivers tomorrow, they can handle that baby there.